So, I'm going to do a quick introduction to what we're doing and what we've been doing and what our business plan is and what's happening in the research development networks. Then we're going to have some updates from the sub-themes, and then we've got some PhD and intern presentations. Some of them are live, some of them are online, recorded, and then we're going to have a bit of a wider group discussion about implementation and what you think would show that we're making a difference, the sorts of things that you'd expect to see from your organisation and how we can make that happen. Because one of the things we have to do as a theme is demonstrate how we've made a difference. But think in practical terms, because it needs to be things that we can measure and provide evidence of. So let's not be too grand in our expectations of how we can show we made a difference. And then we'll do a quick summary at the end around our work plan for the coming year. So if I can get the slides to work. So this is who we are. And unfortunately, Sean's been taken ill today, so can't come. These are our sub-themes. The cross-generational sub-theme, this slide needs changing, should have noticed that, is now a cross-cutting theme. It's not a separate sub-theme. That's one of the things we decided from October 2024, so it still exists, but probably next time we show this slide, that will have gone as a different sub-theme. And you'll be hearing from Children and Family. I'm going to do a verbal update about the adolescents, which is why I've needed my laptop, because unfortunately Paul Moran, one of our co-leads who leads that sub-theme, has been taken ill and can't come today. Kathy Montgomery has to go to a nativity, so she can't come, so I'm doing her update. You know, you'll have forgotten that Kathy didn't do this. Her child will never forget that she missed the nativity if she doesn't go. She'll be whispering it to the rosebud, and older members of the audience will recognise what that's about. And then Clarissa's going to do an update on older adults. The working age adults I'll do quite quickly as well. So this is a quick summary of our projects. We have around 10, I think it's 9 PhDs, just over 20 interns, and about 150 active projects at some time or other. You wouldn't believe how difficult it's been to update this slide. Hours of work and toing and froing on emails. The laptop was steaming. This is our best estimate of the number of publications with a HaCAL co-author or lead author in 2020, 2021, 2022 and 2023. So we had to make the 2023 one. So we anticipate that we'll probably just about be level with 2022 by the end of this year, because I've got one or two that are bubbling under, and I'm sure Clarissa will have, because she normally submits about 1 or 2 a month. Our funding was just under 15 million, our external funding that we've leveraged in this theme alone. That was in April 2023. Since then, we've continued to be really successful. So I'll just run through these quickly. Dr. Giebel, put your hand up in case people don't know Clarissa. So Clarissa leads our sub-theme, and she's been very successful in pulling in funding for the around dementia research. So she's part of the one of the dementia policy research units that the government's recently funded. There's, I think, is it 3 of them? 2 of them. So Clarissa's a subgroup lead in one of those 2. We have a NIHR Research for Social Care project that Clarissa's part of. The PI for that was at Liverpool before she moved to Sheffield, so it was a Liverpool project, but it's headed off across the Pennines. You can boo anytime you like. Clarissa, again, has got 3 European dementia networks that she's involved in. There's a Europe-wide dementia group called Interdem, and they have got some European funding to start to set up some networks, and Clarissa leads one of those. She's also just got, there is some work that isn't entirely, Clarissa, an Australian collaboration, a project grant that's just been awarded, I think, either this month or last month, which is UK equivalent to £315,000, that she's a co-investigator on. The big news in Liverpool was that Merseycare at the University of Liverpool got £10.5 million linked to the Oxford Biomedical Research Centre on mental health. So there's this National Translational Research Centre for Mental Health Research, and there's a Liverpool branch, so they're developing what we call a platform for trials and data type research over the next 5 years, based between Merseycare and University of Liverpool. That's been going for about, I think it's just about a year now. I think it's coming to end of its first year. So that's jointly led by Professor Ian Buchan from Liverpool, who's part of the ARC Big Data Group in Chai, and Nusrat Hussain, who's a psychiatrist at Merseycare. They've already started setting up their programs, and if you're interested in their work, they've got quite a lot on their website. They've recently been doing presentations on their progress to date. HDRCs, this is government, so NIHR, who fund us, so it's the research arm of the NHS, have put together money for funding research in local authorities. So they're really drawing in public health, prevention, and the wider local authority remit for reducing health inequalities. So this is health determinants, which is a fancy word for those things, those sort of strategic policy things that make a difference to people's health, to do with access to transport, green and blue spaces, air quality, access to employment, housing quality, income, etc., etc. So health determinants, research collaborations, they're called. And this is £5 million over 5 years for local authorities to develop the critical mass, so the capacity within their workforce to use and develop and deliver research in their work around how we can reduce those adverse environmental and other aspects of people's lives that worsen their health. So these are HDRCs. We had one in Blackpool that came in the first wave. First wave. You were first wave, yeah, sorry, I thought so. The good news, which was finally officially announced a couple of weeks ago, we've been sitting in my, I can't tell anybody yet, part of my brain, that we got one in Cumberland, which is one of the 2 new Cumbria local authorities. So Cumbria was split vertically. Cumberland is on the east side, and Westmoreland and Furness is on the west side, which is more the coastal side. So Cumberland Authority is now an HDRC. So that was fantastic news. And they will work closely with the other half, because I was involved in some of the discussions though. And the other one is Liverpool. So Cumberland is working quite closely with UCLAN, and they have a member of UCLAN staff that's been working with them for some time to help set this up. And Liverpool works closely with the Liverpool University and Ben Bar. So that's great news, and that will give us real opportunities. And if you were at the last ArcFest, you remember we had those sessions where Blackpool presented the work that they're doing, and the Cumberland and Liverpool were talking about what they were proposing. So we've got those. And I already talked about the capital funding that we got earlier. So these are some of the people that we work with. I've already talked about the global feedback for our annual report, but if you remember, if staff will remember, each theme reported separately on its progress against its objectives as part of the annual report. So all of our short to medium term objectives were completed, and they noted, because I not only said it's completed, but this is what we've done since, building on what we've completed, and that was noted as achieved, but also that we've developed beyond initial expectations. So that was a number of brownie points for that. And on our current live medium objectives, which we hadn't quite completed, and our longer term objectives, which we're still working on, we were commended on our grants, our networks, our collaborations, our support for external studies, and the progress we're making towards building a legacy. So we got a really positive report for this theme. So I've always been good at creative writing, so I'll carry on that tradition. But to be fair, I'm teasing. I think you should all be very proud of the work we're doing in HaCAL, and it's definitely being noted. I talked about the business plan for 2024 to 26, so that we will hopefully hear in the new year whether or not that's been granted. I anticipate it will be, because nobody's asked me for more information, so that's normally good news. I can't believe we bombed that badly that they can't be bothered to ask us if we can change something. So we have one new objective, which is that we were going to expand the adolescent and children and family sub-themes. And if you remember at these meetings recently, we've talked about what we're going to put in that business plan. But just to remind you about that, we've integrated the cross-generational, as I just mentioned. It's going to be integrated across, as is like health inequalities. It's something that we do whenever we can. We think about, so could there be a cross-generational element to this project? How could we get people in different groups to be part of this idea? And they also obviously wants to build on the dementia work. So that is in our objectives. And otherwise, it would just expand and grow what we're doing as before. So we have 3 research development networks. These are cross-theme, but we host them, so it's our job to organise them and invite people. So we have a social prescribing one. For those of you who don't know what social prescribing is, this is non-medicine prescribing for people with different health challenges. So it might be a walking group, it might be befriending, it might be men's sheds, it might be a whole range of different things, it might be mental health work. So there's a whole range of them, but that's called social prescribing. And primary care networks have people whose job it is to guide people to the social prescribing opportunities that would be best suited to them and to help motivate them to take part in them. Thanks very much, Sean. I've got one, I'm okay, I'll survive, yeah. I took Dorcas's. And we have a social and community mental health and well-being research development network led by Rhiannon Corcoran. That's about embedding communities to work collaboratively within a community level things for their mental well-being and their social cohesion, sort of how a community has that community ethos and stick. And as you know, Chris Whitty has always had a big thing about coastal health. So we have a seaside communities and towns and health inequalities network. So that's what we do. So in the seaside one, we have 2 subgroups. There's a beach school subgroup, which is meeting, I think, tomorrow. So that's looking at how we can use the coastline as an educational amenity for children, but also to see if we can make that cross-generational so that elders can join the children and talk about how they used to use that amenity, and it also gets them out and about. And as you know, Eden North has been confirmed now, so that will be part of that going forwards in the longer term. And that links a lot with the Lancaster, Morecambe Bay curriculum, etc., work that some people are familiar with. In terms of the community integration into redevelopment sub-theme, so there's projects, I've talked about the HDRC at Blackpool, which obviously will knit into that. And we've also got the Filed Research Consortia, and they've been getting money as well recently to help develop projects around seaside communities and health disparities. So they're called RENs, but I won't go into those. That's too much detail. There's been another publication come out of the social prescribing one, and we meet regularly. So please do come along to those if you can. And there's some bids that we've been doing, as I've talked about the Emmerich already, which some of these research development networks have been involved in. And Dorcas is now going to come and talk about her work. Do you want me to, I can't really bring a mic down to you. All right with the stairs? I'll give you a hand. Do you want to bring a mic?
Good morning, everybody. As Mark has told you, I'm Dr. Sakeju. I'm one of the co-leads, Paul is not well, and Professor Joe Blair is also busy. So my sub-team is about family and children. First slide, please. What I'm going to present today is to look into how collaborative work together with other acts, how it works and how good it could be. During the COVID, a couple of us were invited by HaCAL, and so they invited us to come and judge some of their projects. Oh, I can see people, sorry, on the screen. And then we have about we are there, North Cumbria, North Thames, North West London, and West Midlands. So 7 acts really working together, which is very, very good. I felt really privileged that I was invited to chair and judge the projects, which I'm going to talk about. Second slide, please. The first project was about child health and maternal services. You can't see this properly. Can you move it? Because it's, I can only see half of it. Anyway, never mind. Oh, that's better, isn't it? Yeah, thank you. So it's about, looking at remote antenatal care for women with high blood pressure. Because high blood pressure in pregnancy, before I continue, I was a midwife in my past life. It can be very dangerous for mothers. And some of the mothers in those areas, they couldn't get to the hospital. So they are looking into have remote antenatal care. And the other one was the necrotizing in premature babies and continuity of care with the BAME community that are pregnant in deprived areas. And the perinatal bundle of evidence-based elements to prevent neurodisability in preterm infant. All these projects, they were very good, but we have to pick some that is the best. Next slide, please. Right. The other project, apart from the maternal services that I judged, there were other workshops that were going on at the same time. And PENAC arranged all this really. Is the child health, mental health, and public health base. I believe that mental health in children is going higher and higher, even in school and primary school as well. And disability and vulnerable populations. So child health and maternal health, mental health. And sometimes, I think I've done presentation on postnatal depression, one of the ACFES before, because that's quite common as well. So we had 4 workshops, and I was involved in 1 workshop. Next slide, please. The first one that we picked really is the effective implementation of maternal health services, which is a multidisciplinary integrated care to support women experiencing mental health. So it's about having the psychologists, midwives, and social worker all coming together so that the woman can get good care, not just antenatally, and it can continue postnatally. And I quite like that. So, but I wasn't the only judge. I was just chairing it. We had to do a score system, and this one got the higher mark. I put their website on because you might want to look to read more about it because I've only got 5 minutes. The brush one is about toothbrush. You would think, what's toothbrush is all about? They find out that a lot of children in school, they don't even know how to use toothbrushes. So this group, they did a research to see what is happening at the moment, and they developed a kit of toothbrush that they can give to schools so that children can learn how to brush their teeth properly. So it reduces decay in children, tooth decay in children, which is also very, very good. And this is about doing a research and putting it into practice. I believe that we can do so many research. If we can't see the change, why are we doing it? So, and this is why I like all these ones. Next slide, please. The other one is to do with young people as well with mental health, and it's about stress among the younger ones. And this one, when they presented it to us, they gave an example of what's happening in the local area and nationally, and we had to then score them to make sure that, they could do it. I will explain to you what happened after they've done all this from 2020, during COVID. All this was all online. I became more expert in joining MMC and Zooms as well by the time COVID is gone. So, and the next one is evaluating models of earth-based domestic violence. And I think, if you remember last year at Chester, I presented something to do with domestic violence as well. And this is about IDVA, not having independent domestic violence person to support them when they go to court. I have been to the magistrate court as well in Liverpool to observe how cases are dealt with, because I was so passionate. I'm passionate about domestic violence, and they won the mark, and they did a project, and they then evaluate it, and they then put it into practice. Next slide, please. The whole idea of this, it might be a short session, but what I want you to go out with today is to say collaboration, co-production. When people work together, it gets better. You get more you are able to answer all your questions, and you're able to work together better. So that's what this is all about. So it's not just one ACT doing it, it's 7 ACT that is working together. Involvement of the public. About 4 of us, or 5 of us, HaCAL, HINA, we were involved in it. And on the 17th of October, we went to London to the Oval, where they presented all this they've put into practice. They've got IDVA in some places now to support the victims or survivors of domestic violence. A co-production was from the beginning, because what they did was make sure they involve the public, and not just public advisor, public at large, patient at large. And it's still continuing, because I've just got an email from Naomi, who is the public involvement manager. They're still looking into how all this is working and if people are still involved in it. And the impact, as I've said before, impact of projects. When we are doing projects and research, we need to make sure we can put it into practice. And that's all I've got to give you. But you've got all the website. If you want to read more about them, please go on their website. Thank you.
Hi, I'm Kathy Montgomery. I lead the sub-theme of marginalised groups. I'm really sorry I can't be at ArcFest today, but it's the Christmas production time of year, so it's got parenting duties. So I just wanted to give a brief update on the existing projects that we've got going on. You might remember, if you were here at the last ArcFest, that Dr. Abby Rose is one of my co-workers, and she leads work to do with maternal drinking and how we can reduce maternal drinking and in women of childbearing age. The ARC supported a stage 1 application for the development of an app to help reduce maternal drinking. So this was both the PPI work that goes into the development of the app, and then the actual work to develop the app and trial it as well afterwards. So the stage 1 bid was successful. And Abby's recently submitted last week the stage 2 bid to the NIHR Research for Patient Benefit, again supported by the ARC, to hopefully get funding to be able to do the work to support the development of the app and also develop the app itself. Recently as well, Abby's also developed a resource which I can share, like a PPI film with a local filmmaker on women's mums' experiences of drinking during pregnancy, and also the advice that they might have received, sometimes conflicting, from their healthcare professionals at the time. So again, that's a really good resource, I think, that tries to work against the stigma against mums who might drink, and really about how we can then try and understand and support them better through their motherhood journey. The work that we have funded by CSL Seqirus, the Liverpool-based flu vaccine manufacturer, is underway. We've got ethical approval from HRA and IRS to start our data collection, qualitative interviews with a range of stakeholders, so healthcare professionals, policymakers, and also patients who are eligible for seasonal influenza vaccines, particularly those who are from different marginalised groups, different ethnicities that might be underrepresented, so minority ethnic groups in Liverpool as well. So at the last ArcFest, when I presented this, we asked for anyone who might wish to be on our advisory panel, and I've kept the list that we received in the voting afterwards. So Anna Powell, our postdoc, will be in contact with anyone who expressed an interest in being on the steering group at the last ArcFest to try and facilitate bringing us together to discuss what your interests in the work are and how you could kind of advise us. As well as that, we've had recent stakeholder events. So we got some internal funding. So myself, a colleague, Harry Sumnall, and one of our profs from health as well, who's a cardiovascular nurse before he came to LGMU, Professor Ian Jones. So we held a recent stakeholder event with local treatment providers for substance use services, local GPs who are particularly involved in substance use treatment. So we had a good representation from Brownlow with Ryan Young and a number of other stakeholders to investigate how we could instigate a treatment pathway for substance users who might need screening for long-term conditions. So drug-related deaths are at an all-time high. And we know that the major cause of death in substance users who are over 40 years of age or over 41 years of age is not the drug itself, the acute drug poisoning. It's actually long-term conditions like COPD or cardiovascular pathology. So we had quite a large event and brought together a number of stakeholders to discuss how we might make this treatment pathway and where the screening might best be placed. And I'd spoken, I'd heard from Mark at one of the recent ARC meetings about the capital bids that the ARC and the Integrated Care Board were successful in securing. So the chance we might be able to have some type of mobile screening service. And again, we'll be asking for some type of input from public advisors into that soon as we develop the treatment pathway and think about the best way that we can pilot any type of screening pathway. And finally, we've had discussions with Sanofi and Moderna on funding work, understanding how intersectional characteristics for marginalised groups, so things like ethnicity, gender, socioeconomic status, culture, employment status, religion, how all of these things kind of interact to dictate specific healthcare decisions, so uptake of vaccination, uptake of healthcare screening. Uptake of travelled vaccinations is a particular interest for Sanofi, to see if we can secure some funding to increase our understanding and develop some recommendations for different types of screening interventions those companies might be interested in, so that we can take that work. And again, we'd be asking for the ARC support with that as we take that forwards. So yeah, that's it. I was asked to do 5 minutes, so I think I've managed to keep it short and sweet. But if you've got any questions about any of this work, please just drop me an email to c.a.montgomery@ljmu.ac.uk, or I'm sure that Mark or someone else in the Health and Care Across the Life course team will be able to pass on my email address to you. And I hope to see you at the next ArcFest. Thank you.
I'll just quickly do the adolescents before Clarissa comes up to do the older adults. So Paul Moran, as I said, unfortunately, he's got a respiratory virus that's going around at the moment. So if he tried to do this, he'd have spent most of his time coughing and spluttering, and he'd have all gone home with a special present from Paul, which I thought he probably wouldn't want. So what we want to talk about the adolescents is actually the next ArcFest, Future Forward, in March, which is at the Liner Hotel in Liverpool on the 12th of March. Great memory. So in that, there will be a workshop session on children at risk. And that will be children from younger children from birth right through to adolescence and late adolescence. So that workshop is designed to bring practitioners, public, commissioners and academics working with children at risk of adverse health and social outcomes across the Northwest Coast, or doing research or implementing research for those groups. So delivering services, commissioning services, doing research for children and adolescents at risk. So that's the group that we were hoping to pull together this year, but for various reasons we couldn't. It's being done with the Improving Population Health theme as a collaborative piece of work. So we're going to do that at the March ArcFest as one of those half-day workshops, probably a half-day workshop. We're going to share learning in that session about how those current research activities and those planned research activities in that topic area are what's ongoing and how they can be applied to improve practice and improve outcomes. That will then inform the ARC's plans for future research and implementation projects to support local action to improve the life chances for children at risk. And there will be those emerging research topics for this theme, but also children at risk is relevant to all of our research themes. So there'll be maybe work there for Improving Population Health theme, for the person-centred complex care theme, and for the equitable place-based health and care theme. And a lot of that work will probably involve different themes supported by MIDAS, who you heard about earlier, the methods groups, and the care and health informatics theme, because they have access to big data. So we have the PLDR.org, place-based longitudinal data resource, that we pulled together in Clark, which Ben Barr leads. We have the CIPHER, which is the big data project that the University of Liverpool leads, along with the Integrated Care Board from Cheshire and Mersey Care, etc. So there's those big data sets. So it's how we can bring all of that together around expanding our work in children and adolescents. So that's what Paul would have said, possibly more eloquently, but with more of a Scouse accent than my Manx one, had he been here. So another triumph for the Manx there. So I'll invite Clarissa up.
Thank you very much. I'm Clarissa Giebel, for those of you who don't know me, and I'm the sub-theme lead of the Older Adult sub-theme lead in HaCAL. Let's figure this one out. Right, so there is, as Mark alluded to earlier in his overarching slides, a lot of work going on in our sub-theme, and you see loads of our postdocs and RAs and PhDs at the table there. So I'm not going to give an overview of the research projects that we're doing, not enough time, but I thought I'd give a little bit of a 5-minute snapshot of recent public engagement events we've held as a team, because quite frankly, they're the most exciting bits of the work we do, I think. So it only took about 2 years of me pestering MP Debbie Abrahams on Twitter and finally getting her to agree, yes, I'd love to come back to my old stomping grounds, University of Liverpool, and do a visit of our dementia research group. It was fantastic to have her there, not only because she's an MP and we link up with policy much more, she is the national lead of the all-party parliamentary group on dementia. So that's cross-cutting across any Tory, Labour, Lib Dems, etc. political viewpoints. So it was fantastic to have her there. She gave a talk about what the APPG does, and we gave a little bit of an overview of what we in Liverpool do, and we also had a public advisor giving an overview of what it's like to be involved in research with us. We've been quite busy doing lots of events recently. We held a gameplay workshop, which I'll go into in a couple of slides, but we also held a Meet the Scientist event. And I didn't know until doing that event, including some of my colleagues, how difficult it can be to try and explain dementia to a 2, 3, 4, or 5-year-old who just wants to collect a sticker because they want to go across all those different stalls and get a free present. But it was exciting, and it made me think, and us as well, how can we explain dementia and what it is to younger generations, which is really important. So that's been some of our events, but kind of the highlight of this year for us has really been co-producing and designing our dementia inequalities game. So it started with knowing our general health inequalities game within the ARC, and we thought, why not try and do something completely bonkers and do a game? So as you might know, we have been doing a lot of research over the years on inequalities in dementia care, health and social care. So we thought, let's try and pull people from different backgrounds together, lived experiences, professional experiences, third sector, funded by the Wellcome Trust. to hold 4 different co-production workshops over a series of like 9 months, starting last year. We first spoke to people about what are your experiences of inequalities, barriers to accessing care, and they really quickly said, we have so many inequalities in getting a diagnosis as well, so let's bring that into the mix. What we then came up with, so you see on the left slide there, the left picture, those are all the different types of barriers that people have experienced, and they are supported by evidence, not just our evidence, but international evidence. And then throughout those workshops, we asked people, if you had to put that into a game, what would it look like? At first, it was like, what? How can you do a game? But it then kind of developed into a snake and ladder kind of game, where, that's the board game. So we've split it into pre-diagnosis stage and post-diagnosis stage on the board game, and obviously we've had substantial support by a game developer, Focus Games, because we couldn't have put this together. So you start, you can play it between 2 and 6 individual, you can play it in teams. The idea is if you come on a scale, you pick up an inequalities card, which will be different pre-diagnosis and post-diagnosis, because we do experience different barriers or facilitators. So you might pick up a barrier card, which might be you're 35 years old, your GP doesn't recognize you might have dementia, and he or she doesn't put you forward to assessment. So that's young onset dementia. A lot of people have these issues. Or you might be from a minority ethnic background. There's a lot of stigma within your community, so you wouldn't even approach a healthcare professional in the first place. If you come on these types of inequality cards and a barrier, you move a few steps back. If you come on a facilitator, for example, you have an unpaid carer who helps you navigate the system, you move a few steps forward. You can also come on a question and activity one. It was a really funny one where you have to do a wall sit, and lots of people at the gameplay workshop did the wall sit just to stay active and fit. But you get a lot of questions, generic questions about dementia. How many people live with dementia in the UK? What are some of the 12 risk factors of dementia? So now we're currently running an evaluation with undergraduate students in psychology, nursing, OT, physio, radiography, lots of types of health undergraduate students, to see whether playing this game can actually improve your general knowledge about dementia and dementia inequalities. And we're also putting together a grant application to try and see whether this could improve knowledge and care delivery in health and social care professionals. So really it's an educational tool. And if you go on the QR code, you're being directed to the Lewy Body Society webpage. That's the game, quick snapshot. We have our January webinar of the forum with Dr. Megan Polden, who's sitting there, and Kim Ward, who is an intern with us in HaCAL, all about music interventions in dementia. And on that note as well, we have just submitted a really intense grant application on music interventions in dementia, so fingers crossed. And you can register there as well. And the last one, which is very exciting, I've been working with Dutch colleagues for well over a decade now. They're doing fantastic work in the care area of dementia. We've learned a lot from working together. So they set up 25 years ago the Living Lab in aging and dementia and aging and long-term care. So we are now going to launch this across the Northwest Coast, and this is also an open invitation for any of you, especially social care organizations. For example, you provide home care services, daycare, respite, residential care, to come along on the 6th of March, because what the Living Lab does is it buddies up academics with social care organizations to really build more partnerships, and for the researchers that are embedded in the organizations to learn about the organization's priorities. So it is very archy, but it's specifically targeted at aging, dementia, and social care. If you know anyone, please share this. It's an in-person event at University of Liverpool, and you can sign up. And that's it from me, Mark.
Okay, so Clarissa realised, because we car shared, as we drove into the car park here, that she'd forgotten the board game, otherwise we'd have it on the table.
But that's because I'm going to the Dementia Action Alliance tomorrow, where I'll bring it.
Yes, but the game is available and it's not too late to get one for Christmas. So if you go on the Lewy Body Society QR code there, they are being sold by the Lewy Body Society. Any profits will go to charity or to the work of the HaCAL dementia subgroup. We're not expecting huge amounts of profits because it's actually quite expensive to produce the games. The other thing that Clarissa didn't mention, and I've played this a few times, it's really exciting because if you have people with lived experience around that table, it really encourages those conversations and that sharing of knowledge and expertise about a barrier that somebody on the table managed to overcome and how they did it, or you need to talk to so-and-so, they know how to do that. So it's really interesting. And I found playing it able to talk about my mother's undiagnosed but probable dementia prior to her death. I hadn't really talked about that before, but in that game it encouraged me to share about that and talk about my experience. So very powerful, great for community groups, great for education. So if you're involved in a group at all or think it would be useful, please do think about putting, I think it's £35 plus P&P, so I think £40 of P&P to get a game. It's quite robust. It survived the kids at the Meet the Scientist. So really good thing to use, I would suggest, and we're very proud of it. We've now got 3 PhD and intern presentations. Are they all online or do we have anybody here in person? We have 2 in person and 1 online, I think. If you've got Alex's, I hope. But we'll do the face-to-face ones first, so I don't know who wants to come up first.
Right, good afternoon everyone. I'm Tom, I'm a current PhD student, but I was an intern last year, so this is just an overview of my internship project that I completed. And so the project was on the experiences and perspectives of members of staff in teams such as dementia teams, mental health teams, around supporting people with young onset dementia. So young onset dementia refers to people who are diagnosed under the age of 65. It's considered a fairly rare, uncommon condition, but there's still an estimated around 70,000 people in the UK living with dementia at the moment. And there's a couple of statistics that I've just provided. There's many statistics that show that it's got quite a negative, there's a lot of negative experiences of people with young onset dementia. The estimated diagnosis rate of 41% highlights that not many people are seeking help. So it's quite hard to access this population. And for people who do seek help, there's an average time to diagnosis of around 4.5 years. Some people I've spoken to, it's taken 6, 7, 8 years to get diagnosed. So when you add that onto that, qualitative studies show a lot of stigma from clinicians, a lot of poor knowledge, misdiagnosis, and a lot of inappropriate referrals. There's a lot of issues. But research that looks within the health service, that's less common. Well, it was less common when I started this project. There's been a few come out since, but what I wanted to look at was what are the experiences of members of staff in teams around around young onset dementia. So that's what I looked at. So I interviewed 16 members of staff. This was during the 3rd wave of COVID, just towards the end of 2021. So it was all done remotely, semi-structured interviews of around 30 to 60 minutes. And I just tried to be exploratory. I just tried to ask people, what do you think is helpful? What do you think doesn't work so well? And throughout the process, I had 2 public advisors, one person with young onset dementia and one carer of someone with young onset dementia, and they helped me with the design of the interview, with the analysis and the reflections on the results as well. And it was reflexive thematic analysis is what I used. So 3 themes were constructed with a sub-theme for each one, and you can split the themes up into participants talking about the role, participants talking about themselves, and participants talking about the service. So when participants spoke about the role of young onset dementia, it was generally around, they felt it was more complex than compared to dementia as a whole. Within that complexity is the need for extra knowledge or specific knowledge. There's also around the ways that you have to adjust how you deliver your role to provide better care, so that more creativity. There might be people who are in full-time work that you need to support, so you might need to think about how to adjust when you work as well. And potentially linked to the complexity, a lot of participants just felt that they weren't prepared to meet the needs of this population, and that caused a lot of anxiety and worry. I think the quote that I've used, there's a sense of feeling a bit overwhelmed by the challenges that they're facing. But they weren't particularly negative about the need for extra knowledge. They're interested. They're interested in the rarer conditions and the rarer presentations, but they felt unprepared because they may have been working in a system that wasn't very helpful to allowing them to the freedom to do the things that they needed to do. So the third theme relates to what I've labelled as an unhelpful system, which again there's two sub-themes to that. One is that the general philosophy of the teams that they worked in, fairly rigid, fairly discharge focused, and then the second sub-theme was around the wider community. There seemed to be a lessening of appropriate interventions, appropriate groups, and even places like care homes and day centres weren't always applicable for people of a younger age. So for the staff that I interviewed, it makes it a lot more difficult to signpost people to helpful interventions when there's not much out there. So the recommendations I had were, we've heard of dementia awareness. I think there needs to be young onset dementia awareness as well. I think there needs to be more endeavours around dementia training. I think Claire Serb talked about dementia training at a recent event, but they've been doing that since 2009, and they've only recently been talking about young onset dementia within that. But I think there needs to be young onset dementia awareness throughout every hierarchy in the NHS, management as well. So a lot of my recommendations are around understanding and knowledge, but another potential solution is developing specialist YOD services, which have been shown to work, but they're very rare and uncommon, so it would be very difficult to standardise that throughout the country. I just put a slide on what I'm doing now, which is still young onset dementia, but it's a bit different. It's on sports, so high impact sports like rugby, like boxing. Is there a link between doing these sports and then developing dementia at a young age? There's been quite a few rugby players recently coming out with dementia at the age of 40, so I want to know if there's something in that, and I want to know what the experience of that is like. So that's me. Thank you.
It was waiting for me to press the button. Okay. Yeah, so hi everyone, I'm Tony Hall. I am a PhD researcher working at Liverpool John Moores University. I'm going to give you a very brief overview of my project and then talk about our first study, which is my systematic review. So our project is called the Evaluating the Feasibility of Installing Visual Adaptations in the Built Living Environment of Older Adults to Prevent Falls. Okay, so first of all, what is the problem? So we know that up to 30% of adults aged 65 years and older are predicted to experience one or more falls per year. And unfortunately, this risk can increase as we age. But when we actually remove age as a risk factor, globally falls resulted in 17 million years of life lost and over 19 million years lived with disability. So research is kind of calling for a more lifespan approach on fall prevention and fall education. And waiting until people reach the age of 65 to start introducing fall prevention methods could be too late. And we all know that prevention is better than cure. To support this, more and more research has begun to explore the idea of the middle-aged faller, and there have been reports of people as young as the age of 45 beginning to display fall risk factors. We also know that concerns about falling can impact falls risk, and this is when people develop anxieties and worries about falling, and this can happen even if someone hasn't experienced a fall. We also know that socioeconomic background can increase falls risk, and although it's not part of my first study, we're going to be using the outcomes to hopefully drive forward PPIE in the second year. But things like Inadequate housing and delayed maintenance can increase fall hazards within the home, and unfortunately, most falls do happen in the home environment. So this brings me on to my PhD, which is looking at the low-cost visual adaptations to the home. So first of all, we have the visual cue, which is known as the horizontal vertical illusion, and essentially this makes low-height hazards such as steps or door trims or thresholds look higher than they are, which increases foot clearance and hopefully reduces falls risk. There's also been some studies done in our lab which looked at optimal lighting, so something really effective like changing the light bulbs to LED light bulbs can reduce that riskier stepping behaviour. Okay, so I have decided to do a mixed method systematic review for my PhD. So first of all, on the quantitative arm, we want to look at what are the effectiveness of home modifications for adults who fall or are at risk of falling. So a recent Cochrane review found that home modifications are effective for those over the age of 65, but as discussed on the previous slide, we need to explore studies on those under that age bracket. And also by considering this kind of at risk of falling, we're able to look at studies that have looked at concerns about falling as an outcome and not just falls themselves, as we know that they can increase falls risk. So, and then the qualitative arm of the mixed methods review is probably, to me, the most important part, which is going to be looking at what are the barriers and facilitators to home modifications for adults who fall or are at risk of falling, and also the perceptions. So the recent Cochrane review found that the modifications are effective, home modifications do work, but uptake is extremely low. So even though we know that they work, people aren't having them put into their homes, so we need to find out why. So the types of studies that we will be included in our review, so to try to capture that lower age bracket, we're going to be looking at anyone over the age of 18 who has experienced a fall or is at risk of falling. They need to be living in a community setting, so we're not looking at kind of long-term care facilities. Any form of home/environmental intervention, and we've kind of got the home and environmental element because the research in studies they use both, so we're going to try to capture all of those all of the studies. And obviously the qualitative element, which is looking at barriers and facilitators, and also the perceptions. So we don't just want to know about the fallers themselves, but also the family members, healthcare practitioners, and social workers. And we're not going to be looking at children, adolescents. There's long-term care facilities that I mentioned before, any observational studies, review, or cross-sectional studies. So here are some of the search terms that we have been using in our pilot. So fall, slip, trip, fear, concern, or worry, and also trying to capture those barriers and facilitators, so adherence, access, facilitator, etc. These are kind of the things that we think may be barriers, but obviously with the nature of qualitative research, we could find some more. And obviously your home, house, environment, modification, adaptation, etc. So the outcomes that are important to us, this is obviously in the very early stages. We haven't submitted our protocol yet, but we are wanting to look at the fall incidences and the concerns about falling, / fears about falling. We're trying to step away from using the term fear in falls research now, as it's got quite a negative connotation, but obviously some of the literature still uses that phrase. And then with the qualitative element, the barriers and facilitators to home modifications for those at risk of falling, and also the perceptions, and also those barriers and facilitators coming from the perceptions of the families, caregivers, and healthcare providers. Thank you.
Hello, everyone. Hope you're having a nice day up in Warrington. I'm sorry I couldn't attend, but I'll do a quick presentation recorded instead. So I just handed in my PhD thesis, actually, just last week, on AI and health equity in primary care. It's a lot to take in the title, but I've used mainly a qualitative methodology to assess how AI can be implemented in UK primary care in a equitable way, in a way that's beneficial for health equity. And hopefully everything goes well with the hand in. Moving on, I'm supervised by Kara Kierans, Mark Gabay, Lucy Frith, and Sarah Rogers. Mark Gabay of ARC fame. All right, next. Okay, as I said, this is the aim, to assess how AI can be implemented in an equitable manner. And I've addressed that aim, and I realize there's a lot of text and stuff in this, they're taken on the thesis. I won't go into details, but I address it through 3 work packages. a scoping review on mechanisms on how AI might affect health equity. Then I take that understanding of the mechanisms and focus on the implementation of AI and assess that through an explorative interview study where I interviewed a bunch of different stakeholders in an implementation context. And then finally, I do a small data analysis on CPRD, nationwide primary care data to look that is being used to develop an AI tool and look at if there's any risk of bias using a very basic methodology, but mostly also as to have a case study to discuss my other findings against. And then I summarize it all. This is the output of the review. Not going into details here again, but the main point is that we have both effects up here from AI in itself, algorithmic bias, for example, an AI trained on, as a classic example is an AI trained on one skin color might not detect melanomas, for example, if it's applied on photos of another skin color. So these things need to be kept in mind. But since AI is only part of the puzzle, so to say, there's lots of other factors in the healthcare system playing in. It can result in all kinds of effects. In the end, effects on the society as a whole when it is implemented in healthcare. So wasting resources, to pushing doctors away, etc. It can affect how patients interact with healthcare. And through all this, it might have an impact on health inequity in healthcare, in primary care. So that's the review. Then I moved on from the review to the interview study, which I've taken the majority of my PhD time and makes up the majority of my thesis. So I interviewed 32. I have 32 different interviews with local commissioners of AI services in primary care, decision makers at the Department of Health and Social Care, among others, AI developers, researchers in AI and healthcare, a bunch of GPs, and 5 patient groups. I use sort of a modified grounded theory approach and boil it all down to this model, where I on the left talk about factors needed for implementation success. That everyone needs to be part of it is what influence means here, that everyone needs to understand what they're talking about, and that we can make everyone understand what they talk about through having a set of frameworks that we can apply on the whole system. The responsibility for making this happen, I go through on the right side, and these represent chapters of my thesis, essentially these different blobs. And to accomplish all of it, we need to build capacity. Easy peasy. In text, the big results is the following. AI will probably impact health inequity in primary care in lots of ways, and it's needed to be understood and assessed more than it is now. Regulation can only do a little bit, but we need to have a baseline regulation to kind of have a minimum level that can be followed by more localized implementation efforts. Everyone needs to be on board. There's a lot of talk about that in the ARC. So patients and GPs, for example, are currently perceived, or they perceive themselves to be less heard, and probably are in the implementation context. It's quite top down, but they need to be on board, both for the sake of equity in itself, but for all other aspects of implementation success. It's very hard to implement something if not everyone who's going to use be affected by the product is on board. There's a lot we don't know about how to do this in the best way, and we need a lot more resourcing in certain areas to make this happen in a good way. So that needs to happen. And whilst this is true for all innovations, the thing with AI is that AI catalyzes a wave of new technological interventions in primary care, and brings a set of new considerations with data bias and stuff on a whole different level. Those things have existed before, but there's so much more acute now. And that's why I argue for that we need a like holistic take on how to improve health equity and ensure that AI doesn't worsen health equity through primary care. I know I'm over time, very briefly, and this I'm not going through. But at the end of my thesis, I kind of take my findings and boil them into a more concrete method of using this in the implementation situation. I'm not going through this now. And this, I think, might be something for future works of mine. But this just goes to show kind of how I boil it all together in the end to a conclusion and something more pragmatic. And that's it. Thank you very much for listening and hope you have a lovely day. Bye.
If you're wondering, Swedish is the accent. So Alex is a GP registrar training in Birmingham. So he submitted his thesis, I think, on Friday. So I think that's the bit he didn't talk about is when he did look at an existing, recently published AI system for looking at risks for cardiovascular disease. There was major bias in it against certain groups. So he was able to demonstrate that current AI systems, even when people had thought they put it together thoughtfully, they had missed the fact that it was disadvantaging certain groups in society considerably because of the problems with the data that AI was learning on. So, we now want to do some discussions about what we should be thinking about for implementation. Can I suggest that we have 4 tables? I don't know how many people we have online. Do we have an idea how many people we have online? 20. So I don't know whether we've set up a system to do an online discussion, but we need to. So we'll have an online table, if we can. Is that possible? No.
Can you see the chat feed on that monitor so we can keep an eye on the chat as well as speak to people in the room? So if you can see the chat feed, at least you'll know what people are saying.
Yeah, so if people can put things on the chat that they would like to see, that's the way to do it. And I will feed that back at the end. So I don't know whether you can talk to each other online. I don't think you can, but please put things in the chat and then respond to the chat. I can see it on here. They can talk to each other. So if you talk to each other online as a group, I don't think I can join you as a facilitator, but I'm sure you can facilitate it between you. You're a very experienced group. So if you could do that and make yourself a virtual group and then in the chat put key points, then I will draw that together. Could I ask, please, that we have a table over here, a table down here, a table up there, and a table up there. So I'm going to break up the pals from older.
12:45 lunch is we're running over.
Are we? Oh, so we are. But can you still spend 5 minutes, because it's really important, just looking at what would impact mean for you or in your organisation? And how might we measure that? And just jot some thoughts down on paper. So if we could have those 4 tables and we'll stick a facilitator on each just to take some notes. So what would impact look like for you and how would you know it had happened?